I wanted to take a minute and acknowledge several members of the Center for World Health Internal Advisory Committee who are here. An organization like this depends on the insights of many. So those Internal Advisory Committee members who are here, would you please raise your hand so that we have a chance to thank you and acknowledge you, and thank you very much for your efforts. I also want to thank the Los Angeles World Affairs Council, the UCLA alumni, LA5 Rotary Club of Los Angeles, and People Media for their support of this event. Our last speaker is going to tie it together for us and really bring us to the ground. John Cohen has covered the HIV epidemic as well as many other issues and diseases in global science for many, many years. He began writing for Science in 1990. And has covered the epidemic in many countries around the world. He is a well-known journalist, as someone who writes with intelligence as well as also with passion. He has been a Kaiser Family Foundation Fellow, as well as received fellowship awards from the Soros Foundation. He has written for many, many magazines, including the Smithsonian, the New York Times Magazine, Technology Review, the Washington Post, the New Republic, but also Glamour and Surfer. So he is diverse and versatile. He lives near San Diego and is also well aware of the challenges of cross-border health and brings his intelligence and insight and passion to that issue as well. So please welcome John Cohen to talk about Global Health 2035, Aspirations and Challenges.
Thank you, Tom, and thanks for having me, and I really appreciate the reference to Surfer magazine. It's one of my most proud accomplishments. I've had the good fortune of working for Science magazine since 1990, and that's allowed me to travel the world extensively covering global health issues. And what I'm going to do is take you through the HIV/AIDS epidemic around the world over several years. I've worked with the same photographer since '97. My presentation is different from many scientific presentations in that I'm really just going to try to flood you with images and tell you the stories around these people who I've spent time with. We've seen a lot of pictures of people. These are people I know, and I've listened to them tell their stories, and I've learned a tremendous amount from them. And so I thank them ahead of time, because that's really the essence of what I do, is I try to communicate what people on the ground are going through. The themes that have come up earlier today are exactly the themes that I've been most interested in, and that's how do you identify success and failure? How do you get more bang for buck when addressing health issues? And ultimately, how do we look critically at the aspirations and the challenges? I've been working on a photo essay book in Tijuana, going there a couple days each week for the last 7 or 8 months. And this is from an AIDS hospice in Tijuana. Yes, they still have an AIDS hospice. It's filled with about 100 people. And I'll tell you more about these individuals in a moment. But there are huge gaps that exist between our aspirations and our challenges. And I think unless we really look at them honestly, we're not going to make the kind of progress that people dream of in the 2035 convergence. And I also want to build off the idea that Richard mentioned, that HIV/AIDS has a lot to teach us about other diseases. In part because this success has been phenomenal. I started covering this in '89, and at that time, there really, full-time I started covering it in '89, and at that time there really wasn't much to offer people. I've seen this enormous transformation, but I've also seen this enormous opportunity that hasn't been met. So in the past few years, we've heard all this phenomenal optimism about getting to zero and stopping AIDS now and an AIDS-free generation. And I want to look at why that aspiration is so far from reality in many places, like Tijuana, which is from my house about a 45-minute drive. So we know the recipe. It's clear. We know how to stop AIDS epidemics. We know how to prevent infections. And these are the ingredients. I don't think there's much debate about this. This is all scientifically proven. And the problem is we don't have enough cooks. We also know the directions, and I've written those out, but that's too long of a slide. Obviously, it takes enormous resources. We've seen this phenomenal surge in funding. And yes, it's plateauing, but if you look at where we went from in 1999, 2000, when UNAIDS and the Gates Foundation things start ramping up, we've gone up above the 20 billion mark at this point from less than $1 billion. So there's money to be had. The generic drug industry has also shown us that it can much more cheaply produce drugs than was once thought possible. On the left, that's in Farmanguinhos in Brazil, and on the right, that's in Thailand. That's the GPO, government manufacturing. India obviously has played an enormous role in this. But everything takes too long. This is in Conj, Haiti. This is Partners in Health called Farmers Hospital. These people all slept on the grounds of the hospital overnight. They woke up, they were waiting in line to see the doctors. These are mainly HIV-infected people or people with tuberculosis. These are all people who I met post-2003, post the surge in funding, post this great accomplishment of antiretroviral drugs. These are people who had no access to antiretroviral drugs. They most likely all died from AIDS. We often don't link TB appropriately to HIV. They are one and the same. They are a syndemic. They go together. They rise in lockstep with each other. In many, if not most of the countries I've worked on the ground in more than 40 countries looking at HIV, AIDS, and tuberculosis. There is no real linkage between these two diseases. In Tijuana, where I'm working now, they are waiting on their first Gene Expert machine. Gene Expert is a machine that can detect multi-drug resistant tuberculosis, but it also can much more effectively detect tuberculosis in HIV-infected people than the standard sputum test that's looked at under a microscope. It's not there. It's right next to San Diego. A vaccine would be the best solution. There is no vaccine on the horizon. I wrote a book about the search for an AIDS vaccine that came out in 2001. It could come out today with largely the same sort of rant and complaint that I made then about what was going wrong. Obviously, the main problem is that the virus is really hard to defeat with a vaccine. Condoms are critical. They're not enough. The same is true for testing, counseling, and education. Absolutely fundamental to stopping HIV, but they're not enough. This is a testing van outside of gay clubs in Hollywood, not far from here, that operates on Friday, Saturday nights, and I think does a phenomenal job. It's not enough. We see in San Francisco, we see in London, we see in Australia, a rise in HIV in young gay men. It's astonishing. San Francisco has, I think, one of the best HIV responses of anywhere in the world. How can it be? Los Angeles as well. How can this be? Part of the problem is that harm reduction is used very spottily, where they're injecting drug use. This is in Puerto Rico. Puerto Rico is part of the United States. If you look at his leg, I'm sorry to show you this, that's a gangrenous leg. They're handing him clean needles and syringes, but harm reduction is a package. If you simply hand someone clean needles and syringes and you don't provide them the health care and counseling they need, you're only doing part of the job. This is a man who I met in Manipur in India, who at a drug rehabilitation center. He's chained to his bed. That is not harm reduction. That's absurd cruelty of human beings. It doesn't really help them stop their heroin use or prevent the spread of HIV. Until 2005, we only had one biomedical intervention. It was AZT for pregnant infected women. It wasn't really applicable to most of the world because it was an intravenous drip. It was too expensive, it was too cumbersome. And at this little tent clinic in Kampala, Uganda, they showed that a single dose of nevirapine could prevent a high proportion of mother-child transmission. That started to change the way that the world looked at biomedical interventions. And then we had this phenomenal success trifecta of male circumcision, pre-exposure prophylaxis, and treatment as prevention, all three redefining how antiretrovirals and medical interventions could play a prominent role in slowing the spread of HIV. These graphics are just showing the proof that these things work. There's medical evidence for each of these things. But we do not routinely seek and embrace criticism. We shy away from it. DC Appleseed is a lawyers group in Washington, D.C. that annually puts out a report card about the city's response to HIV/AIDS. It's a phenomenal document. I think every city would be fortunate to have such a document. Most of the countries I work in run from criticism, and as Richard said when he goes to the United Nations and sees this hurrah thing, most everyone wants to tout how great they are and how great they're doing. We're not going to get anywhere by everyone clapping themselves on the back all the time. We have to be honest about our failures. The harsh reality is this is December 12th in 2013 at the AIDS hospice in Tijuana. I watched this man die from AIDS, and he was driven in an ambulance 2 days before from Laredo, which is down the Baja Peninsula, 14 hours. Why in 2013 a human being with HIV is put in an ambulance and driven 14 hours to die in an AIDS hospice in Tijuana is appalling. We should all be outraged that this is happening. The man on the left who watched the man die, and then we had to wait for the morgue to show up to pick up the body because nothing happens quickly enough. He arrived, I met him in September. That's what he looked like. He obviously needed antiretrovirals. Mexico has a cutoff of 350 CD4 cells before they will give you antiretrovirals. Mexico also, for some insane reason, if you've ever been diagnosed before, they send your blood to Mexico City to have it tested for antiretroviral resistance and for your CD4 count to be documented in Mexico City. He did not start receiving treatment until November 29th. I just found it appalling. But, let's look hard at the United States and our failure. We only have about 25% of the HIV-infected people in this country who are completely suppressed. In other words, only 25% of the people are receiving antiretroviral drugs, taking the appropriate drugs and taking them every day so that they don't spread to other people and help their own health. With 75% of the people not virally suppressed, we ain't going to see treatment as prevention here. It's not going to happen. Systems are overloaded. This is in a hospital in Shlabisa, South Africa. There are beds on the floor. There are beds on the floor. If you walked into UCLA's medical center across the street and saw people with HIV lying on the floor, you would be outraged. They were happy to provide the care they could provide there. Things are getting better there. They have more drugs. They have more tests. It's kind of a success story. This is a woman who was a clinical nurse associate in the United States, and as with many people who were born in Mexico and grow up in Los Angeles and San Diego and commit crimes, they're deported. She lives in a river canal with about 1,000 other people right on the border. That white in the background is actually the border process that we drive through to come into Tijuana. They shoot heroin openly. It's a brown tar heroin, which you can see looks like something like motor oil. Maybe you can or can't see that there. We have a huge problem in the United States with the epidemic shifting to the South and young African American men who have sex with men. It's a part of the world that mirrors many parts of the world where people don't address the key affected populations because they are called marginalized. In my language, they're hated populations. Sex workers on the border towns that we see everywhere, they're hugely ignored. The transgender population has probably the highest prevalence everywhere I've been. So we have an urgent need to ramp up testing. This is a testing van in San Diego that I think is doing it just right. They take your blood, rapid test. If you test positive, they connect you to care. If you test negative, they send your blood to a lab to look to see if they can see the RNA or DNA in it. So then they can determine if you're acutely infected, and we know that in some situations, about 50% of people who transmit are the people who have yet to develop antibodies and are in that acute phase. They then try to identify the partners of the acutely infected people, test them, and break the network. That's how you stop HIV. In Shlabisa, they're doing house-to-house testing of everyone routinely. In Birmingham, Alabama, everyone who comes in the emergency room, it's an opt-out process. Everyone, this woman came in for a toothache, she's getting an HIV test. At a mobile van in St. Petersburg, they target street kids who have a very high HIV infection rate. In Washington, D.C., the Department of Motor Vehicles does testing. And when you pull out a line, they give you a number, so you get right back in line, you don't lose your space, and they also give you a little bit of money for doing this. We need more locally venue-based interventions and education programs where people meet to have sex. This is at a club in Baltimore. That's an HIV prevention table. I worked with a project in San Pedro Sula that went out to the streets to sex workers. That's another way to directly interact. In the drinking holes, the Shabines in Botswana, this woman's handing out condoms. This is where people meet before they go to have sex. We have to change drug laws. Ukraine just recently made methadone legal. It is illegal in Russia. Russia has an epidemic driven by injecting drug use. We know that opiate substitution works. In New York City, which has more injecting drug users than anywhere in the world, the prevalence now is down, I'm sorry, I should say incidence. We're down below 1% incidence. In other words, they have stopped the transmission of HIV in injecting drug use by having a robust needle and exchange program, methadone clinics, and counseling for HIV, for injecting drug users. We have new diagnostics. I mentioned Gene Expert. There's also a new generation machine that can test for HIV antibodies and detect people before the standard antibody test will detect them. We have to address the structural issues. These are at the core of it. There's migration and deportation. There's incarceration, mental health and homelessness. This man lives in a manhole. That's his syringe. None of these photos are staged. How do you reach this man to help him prevent HIV from entering his syringe? How do you reach her as a homeless woman who lived under a freeway in San Francisco? These are sex workers on the street in Mexico City. This is a brothel in Pune, India, and this woman on the right organized a fund to help the other sex workers. This is a dance teacher. The man is teaching the women who are sex workers in Haiti how to make a living in alternative ways to become dance teachers. Those are all creative ideas of how you address it. These are the real issues. They're resources, leadership, and we need more cooks. Countries have to own their own epidemics. I think South Africa has done a good job of showing how you can turn around with Health Minister Aaron Motsoaledi replacing a buffoon of a health minister before him, who created more problems than any health minister ever in the HIV/AIDS epidemic. We have to increase efficiency. This is Ward 86 in San Francisco at UCSF, which I think does an exemplary job of outreach and letting nurses take over the work of doctors. This is an HIV-infected woman in Washington, D.C. who works with the clinic there and drives around and chases you down if you do not show up for your clinic appointment. She'll go to your church, she'll go to your door, and she will scare you. And she will make you come in and get back on your meds. And this is a woman I've worked with in Tijuana who, as an HIV-infected woman, everyone, by the way, has consented to have their photos shown. She was a heroin user who lived in this river canal for 8 years. She's been clean for 12 years. She's on antiretrovirals. She's a peer educator who works with UCSD doing an outreach program and a testing program for these injecting drug users. She is undetectable today. She's doing just fine. So aspirations can meet reality, and I just want to thank Tom for inviting me. Malcolm Linton is a photographer I've worked with, and science has been my great benefactor. Thank you very much.